everyone, I'm Dr. Joyce Habib, and I'm the speaker for today's webinar. Please note down your questions and queries and ask me in the Q&A session. Let's start with today's topic, tumor agnostic approvals. Where are we now and where are we heading? So what we're trying to talk about today are tumor agnostic approvals. There are 6 tumor agnostic approvals to date, and I think the list is going to continue to expand over time. We'll briefly touch base on TMB because we have issues with this as a predictive biomarker, so we haven't really done a good job there. And lastly, finish off with the regulatory and statistical considerations for tumor agnostic indications. So the first approval, tumor agnostic immunotherapy approval, was from pembrolizumab, and it was in May 2017 in MSI and mismatch repair deficient tumors that had progressed despite standard of care and have no satisfactory treatment option. And so the thought process that for MSI or mismatch repair deficient tumors, these tend to harbor a high mutational load, so they would have high level of neoantigens direct against tumor-specific cells. Tumor cells specifically. And so we would, by using an anti-PD-1 inhibitor, we would be unleashing this activity of cytotoxic T cells against these tumors. And the pool data from 5 single-arm trials was used to land this approval. And we've seen an overall response rate in the pooled analysis of 40%. These responses tended to be durable. So in the updated efficacy analysis of Keynote 158 in the non-colorectal cancer cohort, we've seen that 70% of initial responders kept their response at 3 years. And this is despite stopping pembrolizumab, because in this trial, they capped it at 2 years. And for dostarlimab, the approval came in August 2021, a few months after securing approval for endometrial cancer, again in mismatch repair deficient tumors. And this was based on the Garnet multi-cohort studies. This was a cohort that included the pooled data was from cohort from endometrial and non-endometrial cancer. By and large, these were 93% with GI tumors. And the response rate was 42% in that trial, with 9% CR rate. Duration of response was 35 months. And again, in the updated efficacy analysis from ESMO, I think 2022, we've seen that the responses were durable. And if you had 85% probability of maintaining a response at 24 months. Initially, when these were approved, there was no companion test. However, in the past year, we've seen 2 companion tests. The Foundation 1 CDX assay was approved as a companion test for Pembro to detect MSI high tumors, and the Ventana mismatch repair HC assay was approved as a companion test for both dostarlimab and pembrolizumab. And so if we use those for advanced disease, why not try those for earlier non-metastatic disease? And the thought process is that the more advanced the disease, the lower the prevalence of mismatch repair deficiency or MSI high tumors. And at least this is stage specific for a few cancers, among them colorectal cancer, gastric and endometrial cancer. So for instance, colorectal cancer, 15% of stage 1 and 2 tumors are mismatch repair deficient or MSI high versus only 3 to 5% for stage 4 tumors. And if it works in metastatic disease, there should be more even compelling data that would work in the earlier stage setting, because primary tumors are even more immunogenic than metastatic tumors. And this hypothesis was tested in 2 studies that were presented this past year. One was as ASCO and then published in a New England Journal of Medicine. This was the Memorial Sloan Kettering study, looked at dostarlimab for 6 months in rectal cancer that had MSI high or mismatch repair deficiency for stage 2 and 3 disease. And they saw in 12 patients complete clinical responses across the board. None of them needed chemoradiation or surgery. And the responses, none of them had relapse, albeit with a short duration of follow-up is about a year. In the neoadjuvant setting for colon cancer, we've seen the use of Nivo-Ipi, 2 doses of Nivo, 1 dose of Ipi followed by surgery, leading to a pass-CR rate of 67%, and even higher for a patient with germline etiology. Lynch syndrome pass-CR was 78%. So again, none of them had relapsed at the time of publication, but the duration of follow-up was also about a year. So we don't really know what will happen with long-term follow-up, whether some patients will relapse. We're not really sure how pass-CR in colon cancer pans out as an endpoint, since it's not been validated as an endpoint in that cancer. pCR is maybe a valid endpoint, predictive of prognostic endpoint in rectal cancer. So if a patient will have chemoradiation pCR, we may be able to spare them surgery. We don't really know what the value of pCR is in, for example, rectal cancer if they are treated with just immunotherapy, not chemoradiation therapy. Do I see this as becoming a tumor agnostic approach? Probably not. We have this data that was published a few months ago, primarily colorectal cancer, but also a few non-colorectal cancer patients that were given pembrolizumab for about 6 months, and some of them were taken and resected, about 17 out of the 35 patients. Compelling data seemed very promising. Response rate was super high. pCR was 65%, but you can't really make anything of that data, seeing that the colorectal cancers patients were very few among these patients. So I don't really think this is going to be expanded to become a tumor agnostic. It's probably this approach is going to be developed in the specific tumor. The prevalence of MSI or mismatch repair deficiency is high, like colorectal cancer, gastric cancer. We've seen data from gastric cancer as well, and potentially endometrial cancer. I don't think it's going to be tumor agnostic. It remains to be determined what's the best approach. Should we use just PD-1 inhibitors or PD-L1 inhibitors, or should we combine those with CTLA-4 inhibitors? How long should we treat? If we were to choose surgery, use that in a pre-op setting, do we need to use adjuvant immunotherapy as well? Are we going to use that in a surgery sparing approach, particularly for rectal cancer, where depending on location, tumor surgery might be quite morbid? And obviously, when we use these in a preoperative setting, if we use pCR, this is not a validated surrogate endpoint for outcome for relapse-free survival and overall survival across all tumors, right? Certainly, I just pointed out that the colorectal cancer, but also, if we use that for endometrial gastric cancer, certainly this marker needs to be validated first and correlate with survival before we move forward with that. And what about biomarkers of response? In the study that I just showed you, they looked at ctDNA kinetics. They looked at the decrease in ctDNA as a potential biomarker of response. That response was defined in pCR. So it would be interesting to explore biomarkers because not all patients will continue to have response. In that study that I just showed you in solid tumors, some of the patients relapsed or progressed and required salvage therapy. So interesting, but not quite ready. So the second tumor agnostic immunotherapy approval was for pembrolizumab in tumor mutational burden high tumors. And when same thought process for TMB high tumors, that these have high mutational load, more neoantigen, more cytotoxic T cells that you would unleash with immunotherapy. And the way this was looked at in the KEYNOTE-158. This was prospectively planned retrospective analysis of patients enrolled in that study, where they used the cutoff of 10 using to test for TMB using Foundation 1, which was an NGS panel. And the reason why 10 mutational per megabase was used as a cutoff is quite arbitrarily, because it correlated the best with the optimal TMB cutoff that was determined by whole exome sequencing. That cutoff determined by whole exome sequencing had the strongest data as being predictive immunotherapy efficacy in non-small cell lung cancer, but also in other solid tumors. So quite arbitrarily selected endpoint with more than tumor mutational burden, patients with having that biomarker, selected for that biomarker, having a response rate of 29% versus 6% patient with non-TMB high tumors. And these responses seem to be durable. So this landed the approval of pembrolizumab in June of 2020. And Foundation 1 assay, the one that was used in that study, was the companion test. And even though this is the only FDA-approved TMB assay, the MSK impact has also been authorized by the FDA through the 510K pathway. So this is second NGS assay that we can use as well to measure a TMB, a select patient. But if we look at KEYNOTE-158, histology by histology, across the board, yes, you do see higher response rate in TMB high tumors. But for example, if you look at anal cancer, the response rate is substantially lower in TMB high patients compared to TMB low patients. So this variable by histology. And if you look at survival analysis, the PFS comparable TMB high versus TMB low, 2.1 month PFS. And the OS is numerically worse for TMB high tumors, 11.7 versus 12.8 month. And if you see this kind of crossover effect where the blue line dips a little bit and then kind of becomes on top of the red line, meaning that there are patients that are going to progress really quickly in the TMB high population. And very few patients who are at that tail end of the curve are going to have some benefit. So in overall, in net effect, the outcome is numerically even worse. So with the lackluster survival data and this variation in histology, leads us to question whether TMB is truly tumor agnostic, independent predictive biomarker for immunotherapy. And this variation in response rate was also reported by another group, the Yarshawn and colleagues, showing that, for example, I've shown you data in Keynote 158 for anal cancer, but also for mismatch repair proficient colorectal cancer, you tend to see lower response than you would expect for the TMB. And conversely, for some tumors such as Merkel cell and renal cell, you tend to see much higher response, objective response to immunotherapy than you would expect for the mutational load of these tumors. And to that point of that being questioning whether TMB is an independent predictive biomarker, Russo and colleague looked at various tumors, colorectal cancer on top, and at the bottom, various solid tumors, and they tried to look at these tumors and remove the contribution of mismatch repair deficient tumors. So for example, colon cancer, MSI high tumors all have extremely high TMB and respond to immunotherapy. If you exclude MSI high tumors, so mismatch repair deficient protein, not having mismatch repair deficiency of one of those proteins, or not having a polymerase epsilon or polymerase delta 1 mutation, and you remove those from the equation and just leave mismatch repair proficient tumor, you see that whether you have high or low TMB, you have the same outcome with immunotherapy. So really, it doesn't appear that it has predictive value in that subset of patient. But if you also look at extending this analysis to patients with various other solid tumors, mismatch repair proficient tumors, stratified by TMB, more than 10 mutation per megabase, less than 10 mutation per megabase in that study determined by Foundation 1 assay, you see that for some tumors, such as non-small cell melanoma and head and neck, there is an association with survival. Whereas with a lot of other tumors, gastric, urinary tract, or carcinoma known primary, there's no association with survival. So again, it's not really an independent predictive biomarker, at least not in tumor agnostic fashion. The other study, for example, the same results were seen by Samstein and colleague. They was looking at various solid tumors treated with anti-PD-1 inhibitor or anti-PD-1 and CTLA-4 inhibitor, and they see overall this correlation between overall survival and TMB, high TMB, better outcome. But when you look at specific histologies and you look at the cutoff of TMB that is associated with survival in patients treated with immunotherapy, this is substantially higher. For example, colorectal cancer, it's 52.2 versus 13.8 non-small cell lung cancer. So very close to the cutoff that we use of 10, but very much higher for colorectal cancer. And for some tumors like glioma, having high mutational load is actually associated with worse outcome with immunotherapy. So this variation and cutoff across histologies, variation in response histology, makes you wonder whether there's something specific, the immune microenvironment of each histology does play a role. And to that point, McRail and colleague performed this analysis in tumors in TCGA. There were thousands of tumors they looked at, and they were able to find that for some tumors labeled as category 1 tumor, there was correlation between CD8 positive T cell infiltration and neoantigen load. And these tumors like melanoma, uterine, kidney cancer, and adenocarcinoma of the lung, this correlation existed. And for category 2 tumors, that correlation did not exist. So there was no association with high neoantigen load and CD8 positive T cell infiltration, which included, among others, liver, esophageal, gastric cancer, prostate, and breast cancer, and squamous cell carcinoma of the lung. So the same kind of cancer, lung cancer, adeno, category 1, squamous, category 2. And for category 1 tumors, when you treat those patients with immunotherapy, you tend to see a correlation with response rate, but also survival at the bottom. Category 2 tumors, you don't see any correlation with response rate, and for some histologies, you actually see worse outcome with immunotherapy in TMB high tumors. But then if we focus on one kind of cancer, non-small cell lung cancer, where I've shown you that, the cutoff of 13.8 is very close to the cutoff that we use, that it is associated with overall survival, even if we remove the mismatch repair deficiency from the equation. And at least for adenocarcinoma, there's correlation between CD8 positive T cell infiltration, neoantigen load. How did that fare? How did data fare in that specific cancer? Well, not very good. Whether we look at TMB and whole exome sequencing or NGS, we really did not show any predictive value for TMB in non-small cell lung cancer. There was no association with overall survival. So is it an issue of dividing those into squamous now, non-squamous? Because, the non-squamous, the adenocarcinoma, there does seems to be correlation between neoantigen load and CD8 positive T cell infiltration, and just leave off the squamous. We don't really know. Is it the time that the cutoff that we got wrong? I mean, 10 is 10 mutation per megabase, the actual required cutoff to be able to demonstrate efficacy. It's unclear because, that selection was kind of arbitrarily done from the get-go. For example, in this study by Rishuti and colleague that was done in published about a few months ago, they were able to show that tumor burden cutoff, looking at the optimal cutoff, the cutoff of 19 mutation per megabase was the one that had the strongest association with response to immunotherapy among non-small cell lung cancer. So the efficacy, we're talking about response rate, PFS, and OS.